The approach of the EKG we did in a 9-step analysis. In arrhythmias, we do it in 3 steps. First, we look at the QRS complex, or this narrow or wide, where the cutoff point is 0.12 seconds. Second, we look if the rhythm is regular or irregular. And finally, at the third point, we search for the P wave. Cherchez le P. When QRS is narrow, it means less than 0.12 seconds. There's always a supraventricular rhythm, sinus rhythm, atrial rhythm, or AV nodal rhythm. And when the QRS is wide, that means 0.12 seconds or more, the rhythm is ventricular or it's supraventricular with aberrant conduction. Now you will see an important flow chart which will guide us through the analysis of arrhythmias. First step is to differentiate, or there is a narrow QRS or a wide QRS. Cutoff point was 0.12 seconds. Second step is to differentiate between regular or irregular rhythm. And finally, the third step is searching for a P wave. Is there a P wave, and where is it? Cherchez le P. By doing so, we have 4 possibilities. The first one is the regular narrow QRS arrhythmia, within it the sinus tachycardia, and also, if you may say so, the sinus bradycardia when you call it a rhythm disturbance, the atrial tachycardia, the AV or AV nodal re-entry tachycardia, and the atrial flutter. Second possibility is the irregular narrow QRS arrhythmia, and here we can see the atrial fibrillation, atrial flutter with variable block, and the multi-atrial rhythm. Third possibility is the irregular wide QRS arrhythmia with atrial fibrillation with aberration or ventricular fibrillation. And finally, the fourth possibility, the regular wide QRS arrhythmia. This contains ventricular tachycardia or supraventricular tachycardia with aberration. First, we will elaborate on the regular narrow QRS arrhythmia with its sinus tachycardia, atrial tachycardia, AV or AV nodal re-entry tachycardia, and atrial flutter. First, sinus tachycardia. Frequency above 100 beats per minute. Atrial frequency is the same as the ventricular frequency, and important, the P wave is a normal sinus P wave before the QRS. Second form in regular narrow QRS tachycardia is the atrial tachycardia. Atrial and ventricular frequency are equal and of course above 100, but in this case the P wave is not a normal sinus P wave. Normal sinus P wave is upright in 2, is negative in AVR and biphasic in V1, but it's another P because the origin of the stimulus is not in the sinus node but lower in the atrium, and it is before the QRS. Thirdly, in regular narrow QRS tachycardia is the AV re-entry tachycardia and the AV nodal re-entry tachycardia. The frequency is mostly fast, from about 180 till 250 beats per minute, and the P wave is in or right after the QRS, because the depolarization of the atrium and the ventricle will be simultaneously, and the P wave is negative in the inferior leads because of the direction of the depolarization of the atrium. And that you can see often as a negative little wave in the terminal part of lead 2. That's a retrograde P wave. And to see it good, compare the lead 2 with lead 2 of the normal ECG when possible. Here you see a nice example of an AV nodal re-entry tachycardia with a fast frequency of about 200 beats per minute, and lead 2, and you see it below, enlarged and shaded in yellow, the terminal part, the little negative P wave. Negative in 2 because of the direction of the depolarization of the atrium. The difference between AV re-entry tachycardia and AV nodal re-entry tachycardia. In the AV nodal re-entry tachycardia, the circle goes back and forth through the AV node, so there is a narrow QRS complex, while in AV re-entry tachycardia, one of the two paths goes besides the AV node, and when the stimulus forth goes to the AV node and back via an accessory bundle, then we have a narrow QRS, and when reversed, so the forward stimulus goes alongside of the AV node, we have a wide QRS complex. So in the first case, when the forward stimulus goes through the AV node, we speak about orthodrome tachycardia, and when the forward stimulus goes alongside of the AV node, then we speak about the antidrome tachycardia. In the last case, we have the wide QRS complex. The fourth form of the regular narrow QRS tachycardia is the atrial flutter. An atrial flutter is a very characteristic rhythm disorder with a so-called saw-toothed appearance of the P wave. The frequency of the atrial depolarization, so the P wave, is mostly about 300 beats per minute, and the AV node cannot let pass this high frequency of stimulus, so it goes blocking, often 2 by 1, and it results in a ventricular frequency of 150 beats per minute. But it can also block 3 P waves by 1 or 4 P waves by 1. You have then frequency of 100 or 75 beats per minute. So if you see on the EKG a regular narrow QRS tachycardia with a frequency of 150 beats per minute, call it an atrial flutter. In 80 or 90% of the cases you are right, till the opposite is proven. Summarized in regular narrow QRS tachycardia, we know 4 forms, and we distinguish them on the basis of the P wave. In sinus tachycardia, the P wave is before the QRS, and it's a normal sinus P wave. In atrial tachycardia, the P wave is also before the QRS, but it has another configuration, not a normal sinus P. In AV or AV nodal re-entry tachycardia, the P wave is in or right after the QRS, and when you can see it, it's negative in inferior leads. And in atrial flutter, the P wave has that characteristic sawtooth appearance. Helpful in analyzing supraventricular tachycardia can be carotid sinus massage. The SVT can occur focal or re-entry in the atrium, and that's the case in sinus tachycardia, atrial tachycardia, or atrial flutter, or the SVT is caused by a re-entry through the AV node, which you can see in AV re-entry tachycardia or AV nodal re-entry tachycardia. When we perform carotid sinus massage, we stimulate baroreceptors, and that leads to vagal stimulation. And vagal stimulation slows down, among other things, the conduction in the AV node. When the rhythm disturbance or the re-entry is only in the atrium, nothing will happen when the conduction in the AV node slows down. The rhythm disorder will continue in sinus tachycardia, atrial tachycardia, or atrial flutter. When the re-entry goes through the AV node, sometimes when we are successful with carotid sinus massage, the tachycardia stops abruptly. It is not always successful. When you perform carotid sinus massage, do it well. Patient have to be connected to a heart rhythm monitor. He has to lay down on his back, chin up, and stimulate the carotid sinus for about 5 seconds. The place is lateral to the cricoid. And attention please, carotid sinus massage is not without complications. In Dutch literature, there has been describing of CVAs after carotid sinus massage. So when you will do it, first do auscultation of the carotid artery, and if you hear a murmur, don't perform carotid sinus massage. 2 examples of the effect of carotid sinus massage in SVT. In the strip above, you see a small regular QRS tachycardia, frequency 150 beats per minute, and the characteristic sawtooth appearance of the P wave, so it's an atrial flutter. When you apply carotid sinus massage in a correct way, you see the flutter continues, the P waves appear, there is no conduction over the AV node, so the ventriculate slows down, and when you stop with the massage, the rhythm disturbance will continue, so it doesn't stop at all. In the strip below, you also see a narrow regular QRS tachycardia, frequency about 170 to 180 beats per minute, and when you look closely, especially in lead 2, you see in the terminal part of the QRS the negative P wave, so it's a AV nodal re-entry tachycardia. When we apply carotid sinus massage in this tachycardia, the tachycardia stops abruptly, as you can see here, because the re-entry goes to the AV node and the AV node is blocked. Secondly, we will discuss the irregular narrow QRS arrhythmias, and we distinguish atrial fibrillation, atrial flutter with variable block, and multi-atrial rhythm. Characteristic for atrial fibrillation is total irregular rhythm. There is a lack of P wave. If you could see the atrial frequency, it's up till 600 beats per minute, but mostly you see only a wobbly line. In atrial flutter with variable block, we also see the so characteristic sawtooth appearance of the P wave. The frequency of the P wave here is also mostly 300 beats per minute, but the ventricular frequency is, because of the variable block, not exactly 150, but most of the time between 70 and 120 beats per minute. The third possibility of irregular narrow QRS tachycardia is the so-called multiform atrial rhythm. It looks very much like atrial fibrillation, but when you look well, you can see the P waves. And there has to be 3 or more different P waves to call it multiform atrial rhythm. This multiform atrial rhythm you often can see in lung disease, and in contrary to atrial fibrillation, it reacts barely to AV blocking medication. To summarize, for the irregular narrow QRS tachycardia, here also the P wave, or the absence of the P wave, is the key to diagnosis. In atrial fibrillation, an absent P wave or only a wobbly line. In atrial flutter, the characteristic sawtooth appearance of the P wave, and in multiform atrial rhythm, 3 or more different P waves.